Good morning from Pakistan. We are 3 hours behind you, so it's very early next morning. I must start with the acknowledgement to the organizing group led by very dear friend and a very learned Professor Peng Lee, and who has pulled through this presentations and the workshop despite the difficulties due to COVID-19. And to acknowledge ASAP Group and Professor Lulu Broiber, friends who have shared their slides and worked for this presentation, and Ms. Agnes for providing prompt and feedbacks and support for communication. Infectious disease is the leading issue and cause of death worldwide, and you can see the respiratory tract infections are the further leader in that segment. And if you look at under 5 child deaths in low-income countries, then pneumonia and diarrhea are the 2 major leading factors of death in those countries besides the neonatal part. So if you take 3, they will make the whole thing almost. Pneumococcal disease is a major global public health problem that we intend to discuss today. And the invasive pneumococcal disease, pneumonia, and acute respiratory media are the diseases that include this major global health problem. And it is estimated that a huge number of deaths is occurring every year under 5, which are caused by pneumococcal infection. And if you look at the spectrum of deaths by syndrome globally, then pneumonia makes it nearly 90% plus, IPD is 4%, and meningitis is 7%. If you kindly look at the global peak for children under 5, you can see this is a huge number, out of which Asia and stands out at number 1, and Africa. When you combine them, that really almost makes it like half of what globally is occurring. And amongst this, you can see that the pneumonia is there once again very high in Asia and Africa. This childhood pneumonia incidence by the world map once again reflects and shows the shading more in Asia, same as in Africa, and the rest of the countries have a much lower incidence episodes per child per year. And although it also further points out there is a high variability in incidence between countries, and it's worth pointing out that more than half of the new cases occur in less than 5 years are concentrated in India, China, Pakistan, Bangladesh, Indonesia. Only 1 country comes in from Africa, comes in this list, where there is concentration of unfortunate childhood pneumonia. For Pakistan, just to give you a pic, another probably one of the larger countries with population-wise, and you can see we have a very huge number of 445,000 per year. Under 1 year is another huge population, and all-cause pneumonia deaths, 100,000. If you look at incidence rates globally, you can see that the rate is there once again in Asia and Africa. And in terms of epidemiology in Asia, pneumonia mortality remains high in children under 5, and it's true for every country that you see in this list, from Indonesia, Thailand, and somehow with case fatality rates being much higher in Indonesia, and then followed by Philippines, and then Thailand. The two age groups that this pneumococcal pneumonia afflicts is either under 5 or over 75, and this particular comparison between 2014 and 2016 keeps reflecting the same Asian countries on the top, in the top 15. Majority of them are Asian, and then some in Africa. Kindly look at these globes are according to the size of country, number of deaths that are there, and the estimates and figures all over once again re-emphasize that it is horrendous disease element which afflicts and causes death in children under 5. Now, the burden of streptococcus pneumonia and Haemophilus influenzae is depicted in this particular map, and you can see these blobs are very much there, mostly in Asia and then in Africa, whereas the rest of the world seems to have less onslaught of this particular issue. So we know that we need to kind of retread that this pneumococcal disease, pneumonia, kills more children than AIDS, malaria, and measles. It's a major cause of mortality in children in all regions, including Europe. And pneumonia can be viral, bacterial, mixed, whereas the strep pneumonia is the leading cause of bacterial and severe pneumonia. Looking at the one severe and serious aspect of pneumococcus is IPD burden in Asia Pacific region, and you can see the numbers speak for themselves. And here this also covers as to how much PCV7 to begin with covered the spectrum of vaccine typeable as share of this particular. This was given as reference in 2010. And of course, when you look at this map, it reminds you that this is more prevalent in developing countries, and more than half of these deaths are occurring in children globally in 8 countries. And those 8 countries you can see are labeled quite clearly in this particular depiction. There are many pneumococcal serotypes, and I'm not going to labor on it, but of course they are different in regions and different in countries. And from in this particular side, Taiwan being the best studied and recorded situation, you can see that that also differs from South America and Europe and Americas. However, the top common seropathogens which cause IPD and or pneumonia are covered with a variety of conjugate vaccines that have been available, covering up to 95%, 85%, depending upon where you are. But most infecting organisms are covered by these vaccines. Just data from Pakistan's meningitis group, where I come from, and you can see the distribution of serotypes is rather very varied, and that's why the difficulties of in some of the areas. When it comes to WHO statement of 2008, 100,000 deaths from pneumococcal pneumonia in South Asia, and this is data from the countries as listed here: Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. And this was updated in 2016. And generally, you look at the deaths from pneumonia, 11% of them occur in under amongst the 11% occur under the 5-year age group. The other issue, which has been growing and getting worse day by day, is the antibiotic resistance. That we must know that although pneumonia could be treated, one, that many of them are viral and non-bacterial, so to say, but amongst the bacteria, this strep pneumonia, being the killer, has developed antibiotic resistance, and you can see the commonly names of the commonly used antibiotics which take care of things. And this has been there ever since. This is a slide of 2000, and Islamabad, Pakistan, the capital of Pakistan, you can see that antibiotic resistance exists, and this has been rather significant. And even in the age group of younger age group, so. Now, I think we covered, this was a study from Professor Bhutta and Nizami in Karachi, Pakistan, and they attributed deaths due to strep pneumonia being 27,000 and per year, and then debility and disasters that occur with the meningitis or IPD as a consequence. Another study from Pakistan also reflects that there are resistance, and resistance is growing and gaining momentum. Macrolide resistance is rather standing out, and that's why they say that don't use macrolides alone when the strep pneumonia is kind of suspected. The intermediate level of penicillin resistance, especially in children amongst strep pneumonia, has been documented, not in Hong Kong, and this is the reference to it. And so we have a lot of deaths, we have a lot of morbidity, but we also have, along with the drug resistance, as we all know, it's adding to the problem of management of pneumonia and leading to more complications and deaths. There is a socio-economic burden of pneumonia called direct costs, and you can see these are calculated in US dollars, and there is also further indirect costs. So missed work days by the caregivers and terrible costs for primary care doctors and hospitals. So strep pneumonia is coupled with H1 frenzy is a serious element, along with IPD, meningitis, pneumonia. So they're partners in all this, from common disease to serious disease. There are these two major partners that are there. And the reasons, we must therefore prevent the pneumococcal disease so that we can reduce morbidity and mortality of this disease. Now, when we look at the preventive part of the picture, I think there have been good strides made so far, and you can see that the overall effectiveness and impact of PCV has been there even beyond the vaccine time. So then there are bad news, there is good news also, that if you start with this, that total pneumococcal disease incidence has been so much, then effective the individual vaccine serotypes brings it down that far. The vaccine-related serotypes, it brings it further down. However, potential risk of serotypes not included in the vaccine goes up, and therefore net reduction is quite significant, although we have not really succeeded in getting rid of it as such. The point of protection beyond the vaccine sero agents, there is cover for other like seropreventive pathogens, and you can see that the IPD caused by 6-8 die was also further reduced in such. In terms of conjugate vaccine, so far, looking at the seroprevalence, this is how far we are able to cover the sero, serological agents which are causing the disease in amongst the pneumococcal serotypes that's causing deaths. And then it has shown that impact, like in the slide with the PCV7 alone, bringing so much of a difference over the years from 1998 to 2003. And this has not only done so as a herd immunity in the older age population. So if we look at the real world data calculation, how effective these vaccines are, over IPD, this is what the IPD was pre-PCV, with PCV7 and with PCV13. So these are calculations from a variety of countries and on the globe. I must say that newer vaccines will likely extend this protection considerably, all right, and may prevent non-targetable H1N1 pneumonia as well. So future pneumococcal vaccines may prevent 30 to 50% of radiological and fatal pneumonia, which is in true sense a huge impact that can be calculated. This particular study coming in 2009. Nice study coming from Asia and data. So cost effectiveness study in this Singapore from Singapore reveals that it has significant cost effectiveness if herd immunity effects were present. Taiwan once again leads in this data from Asia, and following PCV introduction, replacement in carriage can be said is undeniable. So I think that as a blockage or as a hindrance or as a challenge that is coming up, and therefore replacement disease depends upon what serotypes are involved with the prevalence in the population, and the very well known our Taiwanese friend who presented this data. Serotype replacement, emergence of 3 as a dominant serotype of IPD in ages 2 to 4, 5 to 17. This is Hong Kong data, and PCV10 and 7 and 10 did not include 3, but 13 has included 3, and immune response to type 3 is unfortunately not as strong as against other serotypes. Non-vaccine type replacement is visible right here, and you can see that non-PCV13 pathogens showing a boost or increase right there, nearly touching what we have had in terms of all cases pneumococcal disease. One other aspect of pneumococcal infections and disease progress is due to carriage in children. Overall reduction in the carriage has been observed since introduction of PCV, and that's how herd immunity and replacement and the disease incidence is going down. However, in different places, different types of serotypes are coming up, and there certainly will be something to look at and consider. So I think the answer to the deaths and disease morbidity remains with the PCV. We have had a good drop of IPD. We have children under 5 are well protected, and it also gives herd immunity to non-PCV targets. Costs, health and benefits, and cost effectiveness of adding a PCV to the routine child immunization schedule has made the case is made and must be followed. and this was also further studied in Argentina, that it has not only impact on IPD, on pneumonia, but also to acute otitis media, and making it even much more cost effective. And I think it's important to mention when we talk about pneumonia deaths and consequences, then influenza as a partner of pneumonia must be kept in mind, and it takes a different course of things to end with complications and deaths. And flu vaccination may be one component that will be way forward whenever we want to attain and achieve pneumococcal vaccine. Now, with this thrust, so many deaths, Gavi has given a map of, here is a map of countries which have been approved by Gavi for pneumococcal vaccine, and Pakistan was the first one to take up get this benefit, and has implemented it since 2012 and onwards. So Pakistan has been using PCV10 since 2012, late end of 2012, and there is other in Asia. I think Pakistan seems to be the only one so far. There are many other eligible countries, and obviously they are trying to see what will be the best. The challenges are that the surveillance of laboratory confirmed culture positives is just the tip of the iceberg. One, surveillance doesn't exist. Two, the surveillance by culture positive streptococcal disease is just the tip of the iceberg. We need to have a better surveillance with antigen detection, latex or immunochromatography, or molecular assays like PCR.
Okay, because of the time limit, thank you, Iqbal, for your nice presentation.